Good evening, everybody, and I think we'll go ahead and get started since it's 6 p.m. and we want to be respectful of everybody's time. Welcome to this seminar on innovations in malignant hematology. My name is Jeff Lancet. I am the chair of the Department of Malignant Hematology here at Moffitt Cancer Center. And we have a great program for you here tonight. And can we go to the next slide, please? I will just briefly review some compliance requirements here. So this content from the meeting tonight is not intended to be formal medical advice, and anybody that's with us tonight, anybody in the audience should please consult their physician if they have any questions about their own case or their own care. Please do not rely on information contained in this presentation for immediate or urgent medical needs. And of course, if you have medical emergency, call your physician or go to the nearest ER or call 911 immediately. And never disregard professional medical advice or delay seeking care because of any information contained in this webinar. So next slide. Well, once again, everybody, I'm just delighted to welcome you here tonight. Again, my name is Jeff Lancet. I'm the chair of the Department of Malignant Hematology here at Moffitt Cancer Center. And I am just thrilled to really be able to share with you tonight some of the recent and very important and impressive projects and accomplishments going on within the field of hematology in general, but more specifically within our program. And I'm very lucky to be able to work with some very smart and talented people, leaders in the field, well known nationally and internationally as leaders and experts in a variety of different blood cancers, including leukemias, lymphomas, and multiple myeloma. And tonight's program is really about highlighting some of the unique programs in clinical care and research that are being done right here at the Moffitt Cancer Center and being led right here at our center by several individual physicians within our programs. And tonight we are fortunate to be joined by three true and outstanding leaders in the field of hematology, each focusing in a somewhat different area of disease specialty. We'll be highlighting some of the developments in the myeloid malignancies, the plasma cell malignancies or multiple myeloma, and then in the lymphoid malignancies with regard to lymphoma. And there are three outstanding speakers tonight that will have a chance to give an overview of the research and clinical activities going on within the programs. And at the end of the overall presentation session, we will have an opportunity for questions and answers. So you'll be able to type in any questions you may have into the Q&A part of the webinar screen here, and we will review these questions and ask our panel of experts to answer them. So please feel free to enter questions at any time into the chat or into the Q&A section of the screen, and that'll give us a chance to review the questions and answer them with the best person. So with that, why don't we go ahead and get started? The first speaker tonight is Dr. David Sallman, and Dr. Sallman is actually now an associate member. He was recently promoted. And is also the section head for myeloid malignancies within the Department of Malignant Hematology. He has interest and expertise in myeloid leukemias and myelodysplastic syndrome and myeloproliferative neoplasms as well. So he really does it all in the myeloid world. And he will be speaking to us about some of the really innovative things going on within this program, in particular, some of the focus on precursor malignancies that could be diagnosed earlier and potentially treated earlier in the future. So Dr. Sallman, the floor is yours, and welcome and thank you.
Perfect. I'm here. Thanks very much for the introduction, and really a pleasure to be here. And for everybody, joining, late tonight, I think it's a really exciting time in our department. So again, I'm going to have a brief presentation, but really excited to discuss sort of in the question and answer session. At the end, it can be very specific to the talk or more open-ended. I think we really want to be sort of the world. I think we are, but we want to continue to push the limits as far as being a world myeloid leader. So just to kind of highlight, many different areas in myeloid malignancies. So this can be myelodysplastic syndrome, myeloproliferative diseases such as myelofibrosis, and acute myeloid leukemia. We're really leading the way. Dr. Kamraji has led actually a lot of the approvals in lower risk MDS, for example, with luspatercept and likely imetelstat's soon to come approval. Dr. Kirkendale in our group is looking at ways to eliminate the need for phlebotomy in patients with polycythemia vera, and is sort of on the steering committee for rusfertide, which is in phase 3 trial and accruing at our center right now. Also trying to change the frontline paradigm of these patients with combinations with ruxolitinib, with several agents, including pelabresib, which is a BET inhibitor. In AML, in relapse patients, as well in frontline, there's often a poor standard of care. And so, for example, IMGN is a CD123 antibody drug conjugate. So basically binds a target on the outside of these leukemia cells and is internalized and kills the cancer cell from within. Dr. Sweet was the senior author on really the major presentation of this just at ASH. And I'll talk about this sort of preclinical targeting a little bit later in the topic, but a couple of things that I hyper-focus on is trying to change standard of care, both in frontline high-risk MDS, as well as particularly in P53 mutant patients that have MDS or AML. And so there's an exciting immune therapy called magrolimab, which basically blocks a don't eat me signal. So I like to explain it like Pac-Man, where essentially the cancer cell is eaten as you unblind the immune system. And this is currently in 3 ongoing phase 3 trials, 2 of which are actively accruing at our site. And I would argue that we've treated more patients than anywhere else in the world as far as CAR T and AML patients. We have CARs targeting 33, 123, and CLL1, and a lot of other concepts. So really an exciting time in myeloid group. Next slide. But for our focus of tonight, I want to just describe a little bit to the group of what is clonal hematopoiesis. So basically, this means a mutation in your blood cells. And if you just tap a couple of times, because there's some images here, you'll see that actually this can occur as early as birth. It's actually really eloquent work actually about a year ago. You can identify some of these mutations even occurring in utero. But we very much know that these are an association of age, and really up until about the age of 40 or 50, it's quite rare to see these. But what we're learning is that there's sort of activation of certain pathways that allow these mutant clones to do bad things, not just cancer, but other medical problems at the same time. Go ahead and get to the next slide. It'll be maybe 3 more tabs. So again, if we look at age, up until the age of about 40 or 50 is pretty rare, but you could see at age 60 in each decade of life, it actually really starts to be exponential, and it really as high as 10 to 15% of patients over the age of 60 to 65 will have a mutation in their blood. These are usually at low levels, and for 99% of patients, they may not cause a problem. But we're really hyper keen on trying to figure out which patients it will cause a problem, and particularly for higher risk groups, can we intervene on these and prevent disease from ever happening? Just to give you a framework, in 2015, there would be almost 7 million individuals that would have clonal hematopoiesis. Next slide. So again, it's not just cancer. So very clearly, there is a risk of developing myeloid blood cancers, which I commented briefly on in the beginning, but also lymphoid blood cancers. And then a lot of other issues. Cardiovascular disease or heart disease can be dramatically increased, particularly with certain mutations like JAK2. But there's impacts on bone health, osteoporosis, strokes, heart attacks. Essentially, the whole body, even the responses to infections such as COVID-19, can be impacted in patients that have this. And again, it's very easy for us to detect this, but we really need a very monumental, large effort to better understand how to diagnose this, how to manage it, and again, ideally, how to intervene in the future. Next slide. Click again. So I think what we importantly know, obviously we're a very large cancer center, and I'm sure many patients on the call potentially have had cancer or have loved ones who've had cancer. And actually we know that cases are significantly enriched. So if you look at patients that have had cancer, about 30% of these patients, and sometimes higher, can have a mutation. So maybe if you're thinking of a 5 to 10% prevalence, it's at least tripled. And if you click it again, this has been actually well validated in a number of studies, including ours that was published in a high impact journal by Nancy Gillis and Dr. Padron at our group. Next slide. So I think there's a lot of key questions. How do we understand these mutations before patients get chemo or radiation? Because the problem is those can grow and can become a very bad cancer, such as P53. Can we prevent this? Can we potentially, choose patients that would be better not to get chemotherapies in certain solid cancer settings? So there's a lot of key decisions and a lot of key questions that we would like to answer over the coming years. Next slide. A couple more clicks. So a couple of things. So one is we have access to actually one of the largest banks. This is through our Total Cancer Care. So this is a biobanking repository at our cancer center. So we have DNA from blood that we could evaluate, in 166,000 patients. And we would, through a collaboration with Vanderbilt, have the ability to actually, in a much cheaper fashion, sequence these. So we're really looking to do this and a huge number of samples to really best characterize, particularly cancer patient populations and the impact of clonal hematopoiesis. Next slide. So can we do anything about it? And I think the answer again is yes. So we've actually, there's this pathway, I don't have enough time to get into detail, where basically this is an inflammation pathway that both drives myelodysplastic syndrome, but is also a key driver in sort of these preclinical states. And it's probably a major pathway that if we inhibit, we can ultimately prevent this from occurring. So for example, interleukin-1 beta, which is the cytokine, we have an investigator-initiated trial that I lead with canakinumab in lower risk MDS, but there's already a collaboration with Ohio State where we're going to look at utilizing this in patients that have high risk, not MDS, but this clonal hematopoiesis. And again, can we prevent this clone from getting worse? Can we prevent this from having the disease? A central pathway is actually this cool structure in the middle called NLRP3, and we'll actually be having the first in human trial in a sponsored study entering our clinic soon. This is going to be led by Dr. Zoe Shi, who's actually really a world leader in clonal hematopoiesis, who we just recently recruited here, particularly for this group. And again, we will have a trial in MDS in the near future with a cohort that will be for patients with clonal hematopoiesis in the near future. Next slide. So this is just, we have this very catchy catch clinic. So this is our clinic where we're going to evaluate all of our patients with clonal hematopoiesis. We're going to have really high impact or preference at looking at patients that are going to get definitive chemotherapy, let's say for breast cancer, colon cancer, other cancers, because there's a group of patients, if you have a bad mutation, you probably shouldn't get chemo. And I think that may be a very important consideration. But patients that have high risk, we really want to get all these, one, to better understand, but importantly to give important information and ideally think about interventions over time, including modifying risks such as cardiovascular disease. Next slide. So again, we have a lot of goals. I think the slides will be sent out for the sake of time. I'm going to skip over this, but we really do have a lot of needs. This is going to take multiple coordinators, both research coordinators in the clinic to consent these patients, research assistants to process all of this. So this is a huge funding space. We really need a designated space solely for our catch clinic at the same time, and a lot of resources needed for all the translational science to occur really after sort of this very giant biobanking and understanding process is occurring. Next slide. So with that, again, thank you for listening to me. And again, I'm happy to take questions focused on this topic as well as anything sort of in the Myeloid program at the end of tonight's session. Thanks for listening.
David, thank you for a great presentation. I think it's fascinating and so critically important to recognize that these pre-cancerous clonal conditions are so prevalent in the population and have such a potential for future disease, both in the cancer realm and even in the non-cancer realm, that being able to identify patients early and being able to intervene indirectly or directly, I think is going to have major implications for cancer care over the next several years. And we're thrilled to be able to be leading this effort right here at Moffitt. But moving right along, it's my pleasure now to introduce Dr. Rachid Baz. Dr. Baz is the head of the myeloma section here at Moffitt within the Department of Malignant Hematology. He's also a world-renowned leader in all things plasma cell related and has done extensive work in the field of therapeutic clinical trials in multiple myeloma. And his talk tonight is along the similar lines of identifying and managing patients with precursor plasma cell disorders as a way to improve outcomes and identify patients at higher risk. So Dr. Baz, thanks for joining, and please go right ahead.
Hi, good evening, everybody. Well, thank you for staying on. It's late, but basically, I'm going to talk a little bit about precursor condition to multiple myeloma. One of the questions that patients ask us, actually, oftentimes the first question that patient with myeloma ask us is, "Why did I get this?" And in reality, we've known for a while that patients with myeloma have a precursor condition called monoclonal gammopathy of undetermined significance. It's abbreviated MGUS or MGUS. And all myeloma develops from MGUS. Now, a lot of patients with MGUS can go on living their life fruitfully and not have myeloma in their lifetime. But MGUS can develop into myeloma in some patients. And as a result, we have a precursor condition or, that will lead into myeloma if, given enough time. And in some patients that, we've known about, but we have never intervened. And typically the management has always been watchful waiting, observation, and monitoring, basically. So the thinking is that perhaps one of the ways to intervene and cure myeloma is to intervene early and try to find patients who have MGUS who are at high risk of developing myeloma, and consider treatments or clinical trials that could eliminate that risk. Now, when we tackle myeloma, we have many challenges, and as the slide shows, once myeloma develops, it becomes a relapsing, remitting condition that we currently do not cure. There's been a lot of advances in treatments, and I think I don't recall a time where there was a reasons for optimism more than there is now. So certainly there's a lot of reasons for optimism, a lot of new treatments, but despite that, the disease is considered incurable. And we're trying to figure out how do we get all those therapies, together? How do we best use them? How do we harness immunotherapy, cellular therapy? And the goal here is that, we want to cure multiple myeloma. So one of the main objective is really to look at earlier condition prevention. And that's what I'm going to discuss a little bit in the next few slides. So next slide. Okay, next slide again. So MGUS actually is, as we mentioned, a precursor condition and has about a 1% per year likelihood of turning into multiple myeloma. Now, obviously, most patients who have MGUS, are going to be at risk for other things in life, cardiovascular disease, other cancers, etc. But in a small subset, will develop myeloma, owing that we know that about, roughly 30,000 new patients with myeloma are diagnosed every year in the United States. Now, patients with MGUS, have a mortality that is a little bit worse than what we would expect for their, counterpart. And it's actually a little bit more than we would account just by the transformation or the development of multiple myeloma. So there is a little bit of an increased risk, similar to what Dr. Sallman was describing for CHIP. And, the fact that patients with CHIP have other conditions that arise, and there may be, a cardiovascular risk and so forth to be aware of. There is also, some other association with MGUS and other conditions, dermatologic, hematologic, nephrologic, and so forth that we will discuss. Next slide. So there is a term that is actually now gaining more traction in the medical literature, and instead of calling it a monoclonal gammopathy of undetermined significance, we refer to it as a monoclonal gammopathy of clinical significance. And the four main area of clinical significance includes, the potential to develop amyloidosis with, involvement of the heart, the potential for kidney injury and what we would call a monoclonal gammopathy of renal significance. And there is about a dozen disorders that falls under that category. Monoclonal gammopathy, of neurologic significance, and mainly, in the form of neurologic neuropathy, is it destruction and damage to nerve ending, and dermatologic significance. And there's a number of, conditions that affect the skin and that are related to the monoclonal gammopathy. Next slide. So traditionally, our center has focused more on treatment of multiple myeloma, and these numbers basically they tell you that we see about a tenfold or fivefold more number of patients with multiple myeloma, and we manage those patients, and we see patients who have MGUS. And in reality, we know that the inverse is true. Actually, MGUS occurs in about 4 to 5% of people over the age of 50. Smoldering myeloma, which is an intermediate condition to MGUS and active myeloma, occurs in about 0.5% of patients over the age of 40. So in reality, a lot of patients who have MGUS are not aware they have it. They are in the community and they're not coming to Moffitt because this is not perceived as as a risk or a hazard or a cancer. And so what we end up seeing mostly is patients with multiple myeloma. And if you look at, primarily, for example, in the state of Florida only, we estimate about, 440,000 patients have MGUS and they're unaware. And if you look at even within our primary catchment area, so the areas within, near Tampa, basically, about 100,000 people have MGUS. So there's a large number, and there is a greater risk of MGUS or a precursor condition in general, including myeloma, in patients of African American descent. And so if you look at, the group of patients who are African American, then, those numbers, could be around 70,000 patients in the state of Florida with MGUS alone. Next slide. So, obviously, MGUS incidence increases with age. Our population is a growing population, is an aging population. So this is, a situation or a condition that we're going to be only seeing more of with time. Next slide. Does knowing about it early matter? And we don't have firm data that, it does. However, this is a study done by the Icelandic group. And in Iceland, they looked at patients who, had myeloma, and there was a group that they knew they had MGUS prior, and another group that they weren't aware of having a diagnosis of MGUS prior to their myeloma diagnosis. And when they looked at their outcomes, those who were, known to have MGUS had better outcomes than those who didn't. And presumably, obviously, everybody had MGUS prior to a myeloma diagnosis. So that tells us that perhaps, knowing about this ahead of time does make an impact in terms of outcomes. And this is without doing any special intervention. Now, obviously, there is bias in a study like this because, perhaps maybe there is a lead time bias in a diagnosis that's rendered a little bit early, and maybe we're resulting in treating patients longer. But, this begs the question is, does knowing about it alone could be making a difference? Well, what about if we can intervene and that could make perhaps a greater difference? Next slide. So this is our solution, basically is to kind of look at, developing a precursor clinic or a specific interest in seeing patients who have MGUS and managing their disease. And we would, initially see the patient, have a workup, and then kind of stratify the risk into low risk or high risk. And obviously, low risk patients will be candidates for, lower risk intervention, whereas a high risk patient may be a candidate for a more aggressive intervention. But at the same time, while doing this kind of, clinical pathway, we would have, basically state-of-the-art molecular data that, is going to help us understand better why do some patients have MGUS and develop myeloma while others don't? Is there a way that we can intervene early for those, who will develop myeloma? Is there a specific, for example, pathway that we can target, or a specific, targetable protein that we can maybe target through, vaccination or otherwise, where we can make a big difference? Doing those studies for MGUS is actually challenging in itself, because normally those abnormal cells in the bone marrow are present at a small percentage in patients with MGUS. And when you do molecular studies, you usually need highly enriched tissue with over 90%, involvement with tumor. Whereas in the case of MGUS, there's usually very little involvement. And so that kind of, stretches the limit of what can be done. And we're thinking about single cell omics and things that are, revolutionary as far as, conceived today compared to what it was years ago, but, feasible. And I think with, enough effort and funding, I think these are definitely going to be game changers. Next slide. Now, what about early detection? So this clinic will be mainly populated by patients who get a diagnosis of MGUS when they go to the doctor and they're testing them because, oh well, maybe the patient has some neuropathy. Let me check for this. But actually, the vast majority of patients with MGUS don't know they have it. And so we've partnered with the group at Dana-Farber and a number of many large institutions in the myeloma world to really, launch the a study at Moffitt for screening purposes. And so the same way as you can imagine somebody having a mammogram detecting early breast cancer and curing it possibly, perhaps using a blood test, we can pick up a monoclonal protein, diagnose MGUS, and maybe then think about an intervention that could, cure the disease. Next slide. So, this is what we're talking about. We call that the PROMISE study. The PROMISE study aims to recruit patients who, have a history, a family history of multiple myeloma or related conditions. So that includes amyloidosis, Waldenstrom, etc. And they are over the age of 40. So if somebody has a family history, first-degree relative, over the age of 40, they can sign up online. They can receive a blood kit. And they go to Quest or any lab that is partnered with the PROMISE study, and they will draw their labs, and they will do that for free, and they will get the results back online. And if the results show, well, oh, we didn't detect anything, well, that's great, that you can keep monitoring. On the other hand, if the results show, well, there is a monoclonal protein, then the patient is notified, and they have to, see a doctor and get evaluated for it. So this study also will recruit patients who, one, we said family history because they're at increased risk, but also patients of African-American descent have twice the likelihood of those precursor, plasma cell disorders. And so those also will be included. And so patients over the age of 40 who have either a family history or African-American. Next slide. So I'm going to stop here actually. And, this is Dr. Shah is going to take on, but, the goal here is that, one, identify patients with those disorders, figure out the biology that, is going to lead to, cancer diagnosis in the future, and hopefully think about intervention along the way that can prevent that from happening. Thank you for your attention tonight.
Okay, great. Thank you very much, Dr. Baz, for that very comprehensive and insightful presentation that highlights the really critical importance of precursor myeloma conditions, namely MGUS, as a key target for future interventional therapy and monitoring. So we look forward to hearing more about trials and clinical care advances in that patient population for sure. We're going to finish our formal presentation component of the meeting tonight by introducing Dr. Bijal Shah. Dr. Shah is actually stepping in for Dr. Julio Chavez, who was originally scheduled to speak tonight, but had a conflict and was not able to make it. But we're not losing out on anything by having Dr. Shah here. He is one of the premier world experts in immunotherapy for lymphoma, in particular CAR T therapy. And as you may know, all of you in the audience. Certainly lymphoma and related diseases have witnessed some of the greatest advances in medical history over the last 5 years with the advent of novel cellular therapies such as CAR T. And Dr. Shah has really been at the forefront of the clinical trials that have led to the approval of these new compounds and strategies. So he will be speaking tonight about some of the advances in cellular and immunotherapy and other targeted therapies in lymphoma that have been going on right here at Moffitt. So thank you so much, Dr. Shah, for joining us.
Thanks, Jeff, and thanks for inviting me to speak on behalf of our group. So, as Jeff highlighted, we have really come a long way. When we look back at what we have been doing across the board for lymphomas, I'm really excited to say that I would not be surprised if chemotherapy goes away. I mean, it is a huge prediction, and you can hold my hand to the fire in 5 years. But what we're seeing with immunotherapies across the board, name the lymphoma, follicular lymphoma, large B-cell lymphoma, mantle cell lymphoma, you name it. We're starting to get to a point now with our therapies, in particular our immunotherapies, that I think that chemotherapy at best will serve the purpose of creating a system that's more advantageous for immunotherapy to work. And so short exposure and then really following with immunotherapy to drive the cure. And that's really what we want to do. We want to stop, we want to get out of this old, way of thinking where we're limited here. We're going to treat palliatively and hope for the best. And again, this is already happening. So next slide, please. So before I go into further depth with this slide, where are we now with CAR T? We have done the clinical trials, in fact, led them here, bringing CAR T cell therapy to acute lymphoblastic leukemia. And in fact, there's a trial that we're developing that we'll be leading, taking CAR T cell therapy to newly diagnosed patients with acute lymphoblastic leukemia. So what was once a 3.5-year time course of therapy, we're going to try to shrink into about 2 to 3 months. In large B-cell lymphoma, we've already done 2 studies, and there's one coming to confirm the benefit we've already seen. Again, no longer going through multiple cycles of chemotherapy, really focusing on just a cycle or 2 to really reduce the amount of lymphoma that's present, and then come in with CAR T to finish the job. Shortening that therapy, and again, really focusing on immunotherapy to do the job. Follicular lymphoma, we're also moving up into the frontline setting. Mantle cell lymphoma, we're moving up into the frontline setting. This is going to be the future. But with that, we have to be wary of what happens if it doesn't work. We know for patients with relapsed large B-cell lymphoma that around 40 to 50% of them will relapse over time. So how can we learn from this process? What can we do to better understand why it didn't work, recognizing how powerful it is? And so to that end, actually using some monies that have already been donated, we're really digging into those T cells at the time of progression, really trying to understand, why did they stop working? Why did they stop killing the lymphoma cells? At the same time, we want to try to understand what we can do to T cells to keep that from happening. Can we make a better CAR T cell therapy? And as I'll show you in the coming slides, I think the answer is yes. Next slide. Again, this summarizes where we are, highlighting what pathways we need to target and thinking about it now, not from a one-size-fits-all approach or even thinking about the therapies as sort of isolated events in time, but actually thinking strategically. How do we set patients up for success with immunotherapy from day one? How do we double down or build on those immunotherapy successes as we go forward? Next slide. This, I think, is a really cool and interesting approach. And when we talk about perk or perkiness, it's not a good thing for T cells. Okay, what we see in some T cells, particularly what we call regulatory T cells, these T cells that get in the way of immunotherapy, is they have this marked upregulation of PERK. And, again, this is a reflection of certain stresses within the cell. But the bottom line is, once that occurs, these cells are now going to get in the way. They are going to provide, to drive an inhibitory influence on CAR T cells, or really anything else that tries to come at, try to come at the lymphoma to try and target and kill it. So one of the very interesting things that we're doing is not only categorizing the T cells to try and understand, hey, really what's driving this process, but how do we undo it? And there are now inhibitors of this process that we want to start beginning to learn how we integrate, initially in the lab, and I hope into practice. Next slide. What about those CAR T cells, or even T cells more broadly, that exist in that individual after the lymphoma has started growing? What do we do? How do we build on that? And this is, again, another shot on goal. So I talked about targeting PERK to get rid of some of those inhibitory influences that may be getting in the way of CAR T cell or other immunotherapies. But what can we do with the T cells that are there? One approach is to step back and say, can we engineer it differently? We've been very dependent on literally taking an antibody, normally made by a B cell, drive it into that T cell, and then sort of have it use components that are naturally part of the T cell receptor, what you see here abbreviated as the TCR, have that then in turn signal to the inside of the T cell to say, hey, you need to wake up and respond and do something to kill the tumor cell. Well, that's great when it works. And again, it's great because it's working well, but what about when it doesn't? Can we use a different platform for talking to the inside of the T cell? And that's exactly what we're trying to do here. Again, taking those patients whose T cells are not killing their tumor, reprogramming them, building in a very different receptor. In this case, one that's normally present in natural killer cells, to signal now to the T cell to say, yep, you need to kill that tumor cell. Doesn't matter what your T cell receptor or the T cell receptor components are telling you. Next slide. This is work that is ongoing. And again, I'd hint to the fact that we have some donated money, which has really helped to expedite this process of not just re-engineering what is a CAR T cell and teaching it to signal differently, but can we actually look at the manufacturing process more holistically? Can we step back and say, what can we do to these exhausted T cells to reprogram them? So now they're awake again. They're excited and ready to kill lymphoma. One of the very interesting things or interesting areas of research that have come out is, believe it or not, targeting signaling, and very specifically inhibiting signaling of that T cell receptor, that native T cell receptor on the T cell, can actually improve the output of those CAR T cells. And again, it's certainly not what I would have intuited, but it is what we're seeing. And initially, again, a class of compounds called PI3K inhibitors were used to help facilitate this. We're looking a little bit more broadly now at what are called B cell receptor inhibitors. And I'm going to be more specific, T cell receptor inhibitors, because these drugs do both, to see whether we can rescue these T cells and again, improve the output so that these CAR T cells are better able to kill, less prone to exhaustion. And by the way, we want to do it quickly. You see here our manufacturing. What we're trying to do is really have a mature product ready for delivery really within a week to 10 days. So no, we're not talking anymore about waiting 2, 3, 4 weeks, sometimes longer, for that manufacturing to occur. We really want to drive those cells and really, I think, get the best cells through this process and be able to use it to treat someone in the moment, so we don't end up having to go through all the vices of chemotherapy, other things that we have to do to keep folks healthy long enough to receive the therapy. A lot of really, really exciting things happening. Again, focusing on post-cursor states as opposed to precursor states like my colleagues here, but really trying to take immunotherapy, flip it on its head, and figure out what we can do differently to improve the outcomes for our patients. And that's really all being driven here in the laboratories and in the clinics here at Moffitt. And I'm really excited to be a part of it. So with that, I will conclude.
Thank you so much, Bijal, for a really comprehensive yet concise overview of the immunotherapy and cellular therapy world of lymphoma, which is really evolving. And I think, as you said, becoming more and more of an option in routine care paradigms for patients with lymphoma, things that we were thinking about only using in the most severe refractory disease setting not that long ago are now becoming part of the mainstream standard of care for many patients, and moving closer and closer to the earlier phases of treatment. So it's exciting to think about, like you said, how we'll be looking at lymphoma as possibly a disease that doesn't even require chemotherapy in the future. So we are going to get to the Q&A session shortly, but before I do that, I just wanted to give a really big thank you to our team tonight, in particular, Tyler Wilson, who is the Director of Giving here at Moffitt through the philanthropy group, and he has worked very closely with our department to help launch initiatives and programs to communicate with our patients and our colleagues and people in the community and in the region to share with them what we're doing here at Moffitt. So thank you, Tyler, for setting this up tonight. Thank you so much also to the other members of Tyler's team, Brielle Humphreys and Stacy Price, for putting this program together tonight. You guys have done a great job, and it's a testament to your hard work that we're able to get the word out to our patients and families and community about the work that we're doing here. So thank you, guys. I think Tyler wanted just to say a few words as well. So Tyler, go ahead and take it away.
Yeah, thank you, Dr. Lancet, and to everybody on the call. Thank you so much for attending tonight. We really appreciate having you on to listen about some of these exciting initiatives that we have happening really across the department. So I'm the Major Gifts Director here at Moffitt, and going into my third year here with Moffitt. And in that small frame of time, it's really been remarkable to see the advances that have been made in each one of these sections, in the myeloid section, the multiple myeloma section, and the lymphoma section, and the impactful difference that all of our philanthropic partners have made in each one of those sections, in each one of those disease areas. It's truly remarkable to see how quickly some of those initiatives have advanced, and that's all thanks in part to our philanthropic partners that make gifts to those disease areas. And so if you have an interest to learn more about how your gift can make an impact, or you'd like to learn more about how you can designate a gift to one of these specific areas, feel free to reach out to me. My email is there, my phone number is there. I'd be more than happy to answer any questions for you regarding how you can make a difference, and share more with you about the impact that philanthropy has across our research initiative. So it's really been an honor to be a part of this team. And with that, I'll transition it back over to Dr. Lancet to get to the Q&A.
Awesome. Thank you so much, Tyler, for all you and your team have done to facilitate the work that we're doing with these very challenging diseases, and for kind of being the point person for giving, which is a critical component to our research here. We can't obviously accomplish very much without the support of generous donors for these important projects. So why don't we go ahead and take some questions here. There's a bunch of them in the chat. I'm going to take the prerogative as the MC here to kind of direct the questions to the panel members that I think could answer them the best. And some of these questions will be answered in written form. So if that happens, keep an eye out, and you'll see your question being answered in the box, in the chat box. So why don't we start with a question that I think should go to Dr. Shah. And the question is, what percentage of mantle cell lymphoma patients does CAR T therapy usually help, and how much benefit to overall survival is conferred from CAR T therapy and other potential MCL treatments?
It's a great question. So around 90% of patients will respond to CAR T. If we're going to restrict to those with complete remission, it's around 70%. For those individuals that get a complete remission, that's 70%, we can expect that the majority will still be in remission 3 years later. The exact number is around 70, 80% or so, still in remission 3 years later. The data are outstanding, especially when you take into account that this group was uniformly high risk. So we only enrolled patients who were resistant to our best therapies, in this case, what are called BTK inhibitors, and included those individuals who had very high risk biology, those whose mantle cell lymphomas were growing very rapidly, or who had genetic mutations like one called P53 that normally makes them resistant to our standard therapeutic approaches. It's highly promising therapy, but we can do better. And how are we going to do that? You heard me allude to that earlier. We need to bring it in earlier for those high-risk patients. We need to step away from chemotherapy where we know it doesn't work and learn how to integrate this sooner. The trial that we're going to be doing is going to be focusing on a newer BTK inhibitor called pirtobrutinib. And we're going to try to use that as a way to both reduce the amount of mantle cell lymphoma and hopefully stimulate the immune system at the same time. Then come in with CAR T-cell therapy as a consolidation and really try to improve the outcome for these patients.
Thank you, Bijal. Another question that is on the board here is for Dr. Sallman. And the question refers to the phase 3 imetelstat study for lower risk MDS. And the question is whether we have the trial open here and whether you could comment on this particular trial as a targeted therapy for lower risk disease.
Yeah, sure. So the data were pretty exciting. They press released a couple months ago. Dr. Kamraji in our group was on the steering committee for the trial, and we have participated both in early phases and the IMerge, phase 3 trial, and we expect that it will likely get an approval, probably best case end of the year for essentially all lower risk MDS patients who failed ESA therapy. I think what's exciting is the magnitude of benefit. So some patients can have really big improvements of hemoglobin, and I think that correlates quite a bit with quality of life improvement. And in patients that respond, and it's not everybody, let's say around this sort of 30 to 40%, the responses are quite durable. Some patients actually were on drug for years. There are some challenges. You can get low blood count toxicity from it. So it's not just sort of one size fits all, and sort of it does take some micromanaging of it, but it's exciting. We do have the expanded access version of this. So there are some other patient populations. So many patients in the US have had azacitidine, decitabine, or other therapies. Those were excluded from the phase 3 trial. But we essentially have a trial that allows almost all of those patients on as long as blood counts at baseline. So that would be something that patients could come over for consultation. But we expect it to be approved. And then we're thinking, how do we best sequence? How do we best combine? That's some of our next steps in our lower risk MDS portfolio.
Great. A question for Dr. Baz that pertains to MGUS, that most patients don't know that they have it, and what is being done to help primary care doctors and other specialists to detect it earlier, since it may not be on their radar screen. And then how could they subsequently be referred to the MGUS clinic if nobody else is paying attention to this?
Yeah, I think that's an excellent question. I think, one of the main challenges is that, there is no guidelines currently that recommend, testing for this. And the reason there isn't is because we haven't shown that, early detection will make a difference. However, I think that's where we need to generate the study. That's the importance of studies like the PROMISE studies, that will hopefully lead to, you know, the pattern changing, that lead us to have data that shows that, oh, in fact, this is important to test for, just like we screen for, you know, breast cancer, etc. So before, you know, guidelines will incorporate testing everybody for this or testing some at-risk individual, we have to be able to show that it makes an impact. It's a long road ahead. I don't think that will happen, you know, very soon, but that's the kind of data that's required. In reality, we need to show that not only it is, you know, cost effective, it does save life, but also it doesn't induce a lot of unnecessary anxiety, because sometimes, you know, patient knowing about this might feel worried, and maybe most of them will not need to really worry about this. So, so we need to do the studies to really prove that it has an impact, so that, you know, that eventually will lead to changing the practice and the standard of care.
So maybe on the opposite end of the spectrum, you could also, there's another question, maybe you could comment on about briefly, whether there are any treatments that have curative potential for myeloma in the more advanced stage.
Yeah, that's an excellent question. So, you know, the goal of our program is to cure myeloma. And in reality, there's a lot of treatments that, you know, are actually improving outcomes a lot. And we already talk about, you know, functional cures in myeloma, and a lot of patients with myeloma now can enjoy survivals that, you know, are very long, and they have, you know, in the end, other things in life that are unrelated may become more relevant to their health and more, you know, a greater risk to their health. And but nevertheless, even though those patients are we consider functionally cured, sometimes we don't have a reliable method to get there. And that's where, you know, we need to figure out a little bit more about the biology, which are the treatments to use for each specific patient. And a big part of our goal at Moffitt is to personalize the treatment, to kind of figure out what's the right patient for the right, you know, what's the right treatment for the right patient at the right time. And we have tools now, and I think it's within reach. But we're not quite where, you know, we can actually, you know, cure, you know, majority of patients. I think we'd like to get there, and I think the tools are, you know, nearly at our disposal. Yeah.
Question for Dr. Sallman next, from one of our guests, regarding an 81-year-old patient being a potential candidate for immunotherapy who has relapsed after 8 cycles of Inqovi or oral Dacogen, assuming this is refractory or progressive myelodysplastic syndrome, and wondering if there are any clinical trials relating to immunotherapy that might be available for an elderly patient. So you're the man for this question, no doubt.
Yeah, sure. You know, so we're still at our infancy. So I think we have a lot of excitement. Obviously, immunotherapy has sort of changed the standard of care, you know, for patients with solid tumors, and we're trying to work there now in the setting of MDS. The sort of traditional immune checkpoints, like your PD-1 drugs, like your Keytruda, Opdivo, those unfortunately have not really worked, including in relapse refractory, you know, patients. Again, this sort of CD47 or unleashing the innate immune system, these are mostly frontline trials, although we will actually have a second generation. This is with the company Shattuck Labs that both targets a CD47 pathway as well as has a CD40 ligand agonist, which may kind of dually increase what's called antigen presentation, sort of another way to augment the immune responses. So that trial will allow patients with relapse refractory. I think, you know, the one tricky part is, and that's, you know, my main mission as myeloid section head is to have, you know, a trial for every patient that walks in our door. And I actually, you know, through, you know, funding this is actually extremely important to allow us to do some of these initiatives. So I think, you know, we have some trials. We're also, you know, for the first time doing CAR T and MDS. Patients have to have at least more than 5% blast, so that does prevent some of these patients from going on. But we're one of the only centers to have MDS CAR T trials. Our ongoing CD33 CAR does allow both CMML and MDS patients. So we're trying to get there, but you have to have very much new immune therapy approaches. There's a lot coming in the pathway, including other T-cell engagers and other T-cell activating agents that we're looking at. So we're excited about it, but really, you know, early clinical trial and getting as many patients on these studies is quite critical.
Great, thank you. clearly the field for immunotherapy and myeloid disease is evolving. It's not as far along as it is in lymphoma or myeloma, but and there's a lot of challenges that are unique to myeloid diseases that make it more difficult. But we are getting there and making progress. Let's take a question for Dr. Shah, who always gives very thoughtful answers about anything and everything related or not related to his specialty. The question is, what advice would you give someone with a new diagnosis of cancer?
I think the first thing you want to try to do is interact with a specialist. And I want to go beyond the idea of just a cancer doctor, but I mean a specialist for that specific cancer. You know, believe it or not, the field of oncology has changed so much so in just the 11 years that I've been on faculty. When I go back and try to read how we're treating lung cancer today, I don't recognize half the drugs. And, you know, you start putting that into perspective. What does it mean for someone who has a diagnosis of a small cell lung cancer in the community? Seeing what I see, I would want to be in front of a small cell lung cancer specialist. You know, if there was a such thing as a small cell lung cancer specialist specializing in just the one area of the lung involved, I would want to be in front of that person. You want to be in front of the person who has the most experience and access to the most clinical trials and in general agents available to personalize the care for the person in front of them. When I see patients with MDS, I'm not going to lie to you. I send them to David and to Jeff. I send them there knowing full well that I work as part of the same team, but for that same reason. I want to be in front of my colleagues who know more than even I could possibly comprehend about the optimal treatment approach for that patient with that disease presenting in the way that it's presenting. The same is true for myeloma, Dr. Baz.
Yep, I couldn't agree more. I think there's so many details at every level now with just about every cancer that getting an opinion from somebody who focuses only on that cancer or nearly only on that cancer related diseases is always a good idea. We have a question. Let me ask Dr. Sallman to take this one regarding the ineffectiveness of chemotherapy for TP53 mutated MDS, and maybe to kind of highlight some of the emerging therapies for this very, very difficult type of molecular subset of diseases.
Yeah. So it's definitely, it's a molecular subset of patients that is most dear to my heart. I think it's, you could argue, a group of patients that has the most urgent need for new therapies, maybe in all of oncology. And so it's not, the problem is, almost all our standard options are bad, and chemotherapy, it can work for a subset. So there are some patients that get chemotherapy and go to transplant that can be cured, but that subset is probably as low as, 10 to 15%. And there's obviously a lot of morbidity and mortality associated. So off clinical trial, we actually, for both MDS and AML patients, and we actually feel for P53, it's a singular disease. So if you're MDS or AML, but you have P53, it's relatively homogeneous, and we should think about that patient group together. And even when we think about getting new therapies for patients together. So we think about azacitidine-based approaches, but that's clearly also not good enough. Again, average survivals are less than a year. And so we're again leading some efforts on this. We ran the first ever phase 3 trial with a P53 reactivator called eprinetapop, or APR-246. It was very close to a positive trial, but unfortunately was a negative phase 3, and so that has not gone forward. The currently only ongoing pivotal phase 3 trial right now, which I sit on the steering committee for, is where we're looking at this new immune therapy, this magrolimab with azacitidine, versus the current standard of therapy in AML of azacitidine venetoclax. And it actually allows all patients, so age 18 and up, so sort of independent of fitness. And if that's positive, would be the first molecularly specific approval in the setting of P53 mutant patients. So I think the key is the standard is so poor that we really need to try to get all patients on studies. Now that's not possible. And I think my big message is an out of the box approach the whole way, trying to get the best molecular response, trying to get them to transplant if possible, maintenance approaches after transplant. I really think all these patients should ideally be, at academic centers. Because again, if it's just sort of the run-of-the-mill standard therapy, unfortunately, these patients are not doing well. But we're excited about the horizon for this group and really looking to improving outcomes going forward.
Thank you. It's definitely a huge challenge, but clearly we need targeted therapies against the P53 phenotype, and we need immunotherapy to help overcome some of the traditional mechanisms of resistance associated with chemotherapy. Let me take a question here. Let me first out. It is 7 o'clock right now, and we are trying to wrap things up, but we've had some great questions tonight, and all the panelists are willing to stay on for a little bit longer, maybe 10 to 15 minutes to answer some additional questions. So everybody that is on the line and would like to ask some additional questions, we'll stick around for a bit. If not, we'll be happy to speak with anybody or answer questions offline, as these questions will be archived, and email responses, I believe, will be sent out to the people with the questions. So let me answer a question briefly here. What does it take to change the standard of care? I guess I'll take this one because it's a fairly simple and straightforward answer, and that is clinical trials. So I strongly feel, and I think everybody on the line does tonight, that you can't make progress in cancer therapy unless you do clinical trials to test new and exciting agents and hypotheses. And sometimes they work and sometimes they don't work, but you never know the answer until you test it formally in trials. So we're very grateful for all of our patients and families that participate in trials, because even though that trial may not benefit the person experiencing it firsthand, it absolutely unequivocally helps future generations of patients, whether the drug works or not. So there's no drug out there that has been successful without having gone through clinical trials testing. And the more patients and families we have that are willing to participate in that, the faster we move drugs to the marketplace and improve outcomes. And clinical trials are wonderful opportunities for patients as well, because they typically offer standard of care plus a new agent and ensure very, very careful follow-up and attention to detail. So going through a clinical trial really ensures probably a higher level of care than just receiving standard of care alone, just by virtue of the trial requirements and the need to pay very close attention to just each and every detail. Let me have Dr. Shah answer a question briefly about whether CAR T therapy may be appropriate for splenic marginal zone lymphoma as a first treatment.
That is a great question. And I think it also addresses how we personalize therapy. There are high risk variants of splenic marginal zone lymphoma, and it would be, I think, important to think about how we integrate our best therapies for that condition. The good news, however, is that is a very small fraction, probably around 5, maybe 10% of splenic marginal zone lymphomas. The other 90% are going to not just be low risk, but actually exceptionally low risk. These are individuals in whom we can give a different immune therapy, one called rituximab, in many cases for a very short course, and anticipate benefits that last years, many years. And so we don't want to over-treat when it's not necessary. And so absolutely, we should try to figure out how we can build in CAR T-cell therapy for high-risk individuals, even with splenic marginal zone lymphoma, but also think outside the box about our other immune therapy tools that we still have that are, again, highly, highly effective.
Awesome, thank you. Let's take a live question for Dr. Baz, and the question is a good one. What is the current state of immunotherapy for relapsed multiple myeloma? And I think there might be some discussion about CAR T therapy in this section as well.
Yeah, we have, generally immunotherapy in two broad buckets. One is basically antibody-based immunotherapy, and we have agents like daratumumab, isatuximab. These are CD38 antibody. There's clinically approved. They have activity in myeloma. There is an agent called ilotuzumab as well. It's a SLAM-F7 antibody. So those monoclonal antibodies have a target, and the target's on the myeloma cells. And the general understanding is that you give the treatment, and the myeloma cell is targeted by the immune system. So that is one way, and obviously there is agents that are approved in that scope, and we can combine those antibodies with other myeloma agents. CAR T and cellular immunotherapy is a second large bucket, so to speak, and there are two approved myeloma CAR T. They're BCMA CAR T, so their target is BCMA, B-cell maturating antigen, which is present on the myeloma cells. And they have high response rate in patients with advanced myeloma, responses that are 80, 90%. And the disease control rate that is actually quite remarkable in patients who have little treatment options left. On the other hand, what is a little disappointing that the CAR T in myeloma does not seem to be curative. I think we have to do a little bit better at understanding what is the pattern of relapse, maybe having dual targets, maybe having cells that can persist longer. So there are many strategies that are being looked at to try to augment the benefits of CAR T cell therapy. And in addition to those two approved CAR T cell therapy, there's a large and very growing field of CAR T clinical trial targeting not only BCMA, but other targets. And so I think it's, is really a very exciting field nowadays. And so immunotherapy, which, didn't have a very strong hold in myeloma for a while now, actually becomes a mainstay of treatment, especially in, relapsed refractory disease. Yeah.
We have another question that popped up. Maybe I'll ask Dr. Sallman to take this one. Patient with MDS and hemochromatosis, which obviously complicates the matter a little bit with regard to iron overload and the potential for iron overload in a disease that requires transfusion to begin with. Any suggestions for treatments general suggestions for treatments in this type of condition?
Yeah, I mean, there would obviously be some questions, and obviously we always welcome, patients to come see us as well. Is this, primary hemochromatosis? So is this, a genetic predisposition for patients that hold on to more iron, which is common in Caucasian populations, and, at least one mutation, two mutations or actual disease is rare, but definitely can occur. So it would be a challenge, obviously, to have both that and MDS, given if a patient is blood cell transfusion dependent, because obviously that's your main way to get away from it. There are multiple, both parenteral and oral. We typically try oral, chelating agents, and they can work. I think my analogy that I always like to use in MDS is, if you have a bathtub overflowing and I give you a thimble to empty it, that's not that effective. So you have to kind of turn off the faucet, and then the thimble may work over time. And so I think in that regard, if a patient is transfusion dependent, really getting them on a therapy that eliminates their need for transfusion, and that's a major goal, particularly on clinical trial as well. But I think in the same time thinking about chelating patients, particularly that lower risk group of patients. Now, clearly, if you truly have both primary hemochromatosis and MDS, then chelation would definitely need to be part of the course. At the same time, just a brief comment, like if people who have high risk disease and other things like that, we focus less on that because it's never really been shown to improve survival, and they do have a moderate amount of toxicity, including financial toxicity. So it is kind of personal, medicine based on the situation and the disease state.
Great answer. Insightful as always. I think we've come to the end of the questions. We've had some great ones tonight, and obviously a well-read, educated audience that makes these discussions that much more interactive and useful for everybody. So I think what we'll do is we'll wrap up the program right now. And I just wanted to thank the panelists, Dr. Sallman, Dr. Baz, Dr. Shah, for participating tonight and answering these questions. And obviously, again, a big thank you to Tyler Wilson, Stacy Price, and Bijal Humphreys for putting this program together. We encourage everybody and anybody that has further questions to contact us. We're happy to see patients, live, preferably, or by virtual visits in some circumstances at any time. And we feel like our program has new and some really outstanding research going on that makes it worth people's while to come and spend some time with us. But it's been a great evening, and thank everybody in the audience for joining tonight. And I hope that this session was useful and provided some guidance about your own healthcare issues and answers to other questions. And please reach out to us, and in particular Tyler and his group, if you'd like further follow-up or you have further interest in discussing any of our programs. And with that, I will say to everybody, have a wonderful evening, and I hope to see some of you at some point, and happy to answer any questions down the road. Thanks so much.